Welcome to PalliCovid ECHO sessions 4. And introduce myself. My name is Arun. I am recently joined as a new project coordinator in this ECHO program. And today our sessions on triage and COVID-19 with special reference to management of ethical issues. The sessions will carry out by Dr. MHOIRA. Welcome, MHOIRA. And how and how to Suresh sir will be a brief discussion.
Thank you, Arun. So today it is a very important session because many of us, when we see from outside, we have many doubts regarding the how to treat the patient when patient needs many ventilators, when there is a scarcity of resources. So when should we discuss the goals of care? So all this will be discussed by Dr. Myra EFLM. She's a specialist palliative care physician, currently holding two roles as head of palliative care in Makerere University, Uganda, and medical director of Cabes International Trust, Scotland. And Moira has a particular interest in international palliative care and is committed to working alongside partners in developing world to build capacity, offer mentorship, support curriculum development, and new models of care. Since 1998, she has traveled to Eastern Europe and traveled extensively within India as well as Africa, leaving NHS in 2005 to allow her to work full-time in international setting. And it's our pleasure to welcome you, Myra, and it's over to you.
Thank you so much. I'll just share the screen. It's delightful to be with you all today. I'm really hoping this is a session that allows a lot of discussion. Sorry, let me just get this on here. Can you see that at the moment?
No.
Not yet? Okay, let me try again. How about that?
Yeah.
Okay, fantastic. So let this be a session that we have plenty discussion. If you have real life examples, let you bring them to this session. Use our chat function. I have a background in internal medicine and in palliative care, and we've been working very closely with our critical care colleagues looking at this issue here in Uganda. And it's been a privilege to work with the PalliCovid and PalliM India team. Now, as we start, if you don't have your ebook downloaded, please can you do that? So just click on this link or look for it, because we're going to be going through the algorithms. I know many of you have already done this. If so, have them ready. Sometimes it's hard to read on screen, but if you have them on your own device, you'll be able to read them more easily. We're going to look at the background of ethical decision making. We're going to particularly look at those balancing issues that Sunil has already talked about. And then we're going to focus on the triage and goals of care algorithm. And underpinning that are going to be the values in which we approach this issue and the values of our patients and our healthcare and social systems. So as we start to think of that, maybe you didn't expect me to ask you about values. Have a think. What are the core values that you have as you approach working in this COVID-19 pandemic setting? Some of you also may not be familiar with palliative care. I hope actually many of you are not, because we want to have this discussion in a wider forum. And so we've linked to this PalliCare app. It's produced in Bangalore. It's got very useful symptom control guidelines for the usual palliative care settings. We'll also be sharing with you through the PalliM India site many other ways you can get resources and you can train further. Okay, have you got your values thought through? And have you got your ebook downloaded? And if so, we'll continue. Ethical decision making. I think we're familiar with the pillars of ethics, of the pillars of ethical thinking and practice. And if you're not familiar, we'll remind you on the next slide. But these are guides to help us think through decisions and are particularly relevant when we have these crucial life or death decisions to make. And it's important we do think them through. Otherwise, we begin to think that we are the ones who make these life or death decisions. And that is the source of some of what's been called moral injury, when people find their personal values and their ethical decision making is somehow not in sync. There are cultural contexts to these. We're particularly making these echoes, looking at low or medium resource settings. And of course, those are also underpinned by legal frameworks. Ideally, our legal frameworks reflect good ethical practice. This is a balancing act. It's a balancing act where we look at the benefits to someone and the harm. We look at, as I say, the legal context. We look at the wishes and best interests of the patient and the family and the wider society. And finding that balance can be challenging. In fact, it can feel like it's almost impossible. But I want us to just think through how we go through this step by step, how we link with our colleagues. We don't feel we're doing this alone. What principles can help us, and what values can underpin that. I think you will have remembered these 4 principles when I mentioned them. But let me just highlight them again. Autonomy. The right for a person to make their own decisions and express their own wishes. Of course, to do this, they have to have effective communication and ideally an atmosphere of openness and trust. We also need to know, does the family understand these preferences? In some contexts, autonomy seems to drive all decision making. But remember, we have other principles. Is what we're doing going to benefit or do good to that patient and family? And on the other side, is there going to be harm? That's the principle of non-maleficence. Are we doing harm? And remember, harm can be doing inappropriately interventional treatments. So if someone is not going to benefit, for example, from invasive ventilation, then to start invasive ventilation may actually be doing harm to our patient. Similarly, if someone needs good symptom control and we don't give that, and good psychosocial support, then we may be harming that patient. And lastly, this issue of justice. So how do we balance the individual needs in that wider context of resource limitation and the fairness of society? I want to touch on collective decision making. Autonomy, of course, drives it. Autonomy is the patient's right, a person's right, to know what is happening to them and to make decisions. We live in collective societies where people may choose to balance their autonomy or to use their autonomy in a collective way, where families and the wider context are involved in those decision makings. I think most of you will not see a patient alone, but you will see them with family members, maybe many, many family members around. Now remember, that doesn't take away the autonomy. We still need to communicate with our patient, but we see them in the context of a family. Be careful to not allow yourself to get into a situation where the family are driving the decision making, but of course try and be on the same side as them, so that together you are with the patient, trying to make sure you are doing something that is going to be of the greatest benefit and the least harm. This concept of Ubuntu is from Southern Africa. It's talking about I am because of who we are. And Bishop Desmond Tutu, who you may know, famous for his truth and reconciliation work, talked about his humanity being caught up and bound up in what is yours. In Manipur recently, I visited colleagues working with the Kuki people, and they had this concept of kanko, that actually what benefits the society is what is right for the person. And those two things are inextricably bound up. And they talk then about indigenous wisdom being something we need to re-find in our modern societies. I want this justice principle, the last one, because it is tricky in a situation right now where we may be concerned that we're going to run out of resources. Resources particularly in terms of intensive care management. I just want to say a couple of things as we look at this. Number one, I think those of us in low and middle income settings wrestle with this day in, day out. Not everyone is going to get that heart transplant. Not everyone is going to get access to dialysis. Our urban and rural poor populations, we are fighting day to day for them to have better access to universal health care, to essential medicines, to shelter, to food. So this new set of decisions around COVID comes in the context of balancing resources that we do routinely. And if we are going to, in a pandemic situation, have to make those decisions quickly, we need to have our frameworks and thinking and our backup systems in place. And we need to remember another principle, and that is of futility. I touched on this when I talked about non-maleficence. If what we do is not going to be having a reasonable chance of benefiting our patients, we have no ethical responsibility or obligation to do that. And I also want to just underline that this issue of intensive care management, increasingly we are realizing that invasive ventilation is not benefiting everyone, even the most seriously ill. A lot more attention has been paid into non-invasive ventilation and to upstream management. So let's not get so worried about the issue of invasive ventilation, we don't think of the whole ethical framework. Now, there's some excellent documents, particularly in an Indian context, to help us with this. And I particularly draw your attention to articles, a series of articles in the Indian Journal of Critical Care, some of which were joint position statements with palliative care, and one of which has just been published and particularly looks at the intensive care environment for COVID-19 patients. Of course, we're going to look more at the triaging of patients in order for them to possibly not reach or reach palliative care, a bit more frontline. But if you want to think more about the inside intensive care triage, please refer to this paper. And you can see this graph from a previous one that just takes us through step by step how we might make difficult decisions within an intensive care environment and how communication, documentation is incredibly important. We do have legal frameworks in every country that we're working, and in India we have a change in the legal framework at the Supreme Court, although how this is actually being rolled out at state level and institutional level is not entirely clear. I draw your attention to two very helpful documents that came out recently from Manipal and from AIMS Delhi. And you may have your own ethical frameworks within your country and within your institution. It's important that we are aware of these and are adhering to them in our practice. So it can feel a bit like a maze. How do we find our way through, particularly if we're under pressure and the time is limited, and maybe we're being put in a position that we're not comfortable with. We're not used to these conversations. We've been brought in from another area. We're working outside our normal scope of practice. Have you thought about those values? Just think for a moment more. Because when we try and find our way through situations like this, we need knowledge, we need skill, we need frameworks, we need practice and people who are going to supervise and mentor us. But underpinning all these are our principles and our values. And I was very interested when rereading one of those papers I just mentioned, that they had two quotes. One is a famous quote from India, from one of India's greatest poets. Death is not extinguishing the light. It is putting out the lamp because the dawn has come. This is trying to think of end-of-life care and decision-making in the context of life and death. It's not us that is simply making those decisions as if we were in charge of life and death, but we're part of and privileged to be part of these journeys for our patients. And also another quote, which reminds us that inappropriate intervention can actually seriously impact on the dignity of a person at the end of life. So COVID-19, vulnerable patients and families, fear, people feeling quite desperate, worried that they're going to somehow be discriminated against. There's a lot of stigma You will have read of those terrible situations of doctors who can't even be buried if they've died of COVID-19, and I'm sure this also affects other people, of people being chased away from their homes or from their communities. We're seeing holistic issues not being well balanced. We're seeing, of course, unequal access to resources. And we're seeing people under extreme language. We're also seeing language that is not good, language like suspect and victims. These are all things we need to try and move away from in the midst of this pandemic, which affects us as well as our patients and families. So as we start to think of the actual frameworks, we need a strategy in place. This is the WHO link to an updated strategy document that they're using. In your ebook, you can see the Kerala strategies, which are being quite rightly praised for their reach from right in the community level to the hospital level, using particular settings such as the Taluk Hospital. But you need to have a communication system within that for the healthcare workers and the general population, as well as those affected by COVID-19, a way of managing, testing, information, treatment, and triaging, which is relevant to the specific level that people are working at. There really importantly must be support for holistic issues, and that includes staff support, who are sometimes feeling very exposed at the front line of this pandemic. There are a number of tools in the ebook. I draw your attention to this tool because we're going to mention it in a moment when we look at the first of the algorithms. And this is a tool to help us with effective communication. If you want to know more, please watch the specific session on communication. But this is a tool called the Spikes tool. It reminds us to try and set the situation. Now, if you're in a pandemic scenario, you may not be able to do this in great detail, but even your body language, even with PPE, the way in which you angle your body, the way in which you use the communication tools you have, your voice, maybe your eyes, maybe something on your outside your PPE that identifies you. Try and make sure that's a picture with a smile if you can. We need to assess the patient's perception. We need to find out how much they want to know and if they would like their family to be part of that. Give information at the right pace, without jargon, and of course respond to the emotional and empathetic needs of the situation, as well as making a summary and going forward. Remember, most of us miss these middle steps out. We go straight to the last one and we give information without having set the scene. And please remember to do this. Even if you do it fast, the more practiced you are, the faster you can do this effectively. Okay, algorithm 6. Find it in your ebooks if you haven't found it. If it looks small on screen, please refer to this on your device separately. But in this algorithm, we're trying to work through how we support those goals of care discussion. And can I encourage you, if at all possible, have these goals of care discussions early. If you're looking after patients with chronic illness, start having them. Don't wait until there's a query COVID-19 diagnosis. Talk to those who are in high risk categories, those with multimorbidity, those who are older, those who are living with quite severe functional disability. Talk to them about these issues in advance. The comorbidities are well described now, and I think you can read about them. Hypertension, diabetes, and so on are being associated, as well as chronic lung disease, with poor outcomes. Be prepared. This is when your Spikes tool will come in. This box is exactly what we want to do. Try and make sure you're having these conversations effectively and you're managing the context as far as you're able. And you're finding out the preferences. That's one of your autonomy checks. What does the patient want to know? And would they prefer a health proxy to be involved? Now, we can use health information here. Health information that's been produced at a national and local level, ideally in the language of the patient we're talking to. Much of that health information can be reassuring. We know that most patients with COVID-19 are going to do very well. Remember, of course, to balance that reassurance to the situation. Don't use false reassurance or false hope, but be realistic and be helpful and empathetic in the way that we do this. The nurse protocol is in your guideline and will be talked about in another session, but that's a way in which we can reflect and use empathetic responses to help us have this goal of care conversation in a helpful manner. Remember, if this patient is someone who is unlikely to benefit from interventional referral, for example, to ICU or critical care, please do start to discuss end-of-life care and symptoms. Please look at and document their preferences and evaluate what is needed in the context you're in, and you may need to get backup from other colleagues in doing this. We'll go on to this in a moment. This is the second half of algorithm 6, and it really just explains what I was talking about earlier. So please look at this. If you don't know about the SPARKS protocol, look at it. If you're not familiar with empathetic responses, here is a nurse protocol, which helps you with that. And really that's all about listening well, actively listening, and then reflecting back what you hear. And remember, even if we're doing this over a telephone, via WhatsApp or virtual communication device, we can still use those verbal skills. Our non-verbal skills are more limited. They're not absent, they're more limited. But of course, there are many verbal skills we can use. And there's some examples here of how we can do this, to reflect, to give time, and to explain. Okay, so that's our goals of care thinking, and this is balanced by our ebook algorithms on communication and psychosocial support. Let's move then to algorithm 5, which is specifically looking at the ethical issues and the ethical framework. This is an algorithm to help you move through. You may wish to print this out, have it handy, just as a reminder as you work through the issues with the person in front of you. And of course, this also links to the other algorithms and backup that we've talked about. So someone with no comorbidities and no premorbid conditions should go through the normal treatment protocols, and that will involve escalation up to critical care and even intensive care management for some. Let's focus more on those with comorbidities and with significant worsening symptoms, and we've talked about some of those comorbidities. Some of these may still benefit from ventilator support, and we're suggesting you use the number of comorbidities, the functional status, particularly using the World Health Organization performance status, if you're not familiar with it, that I'll show you in a moment. But that's a simple way of trying to understand how much this person was managing to do in relation to daily activities. But those who were managing most of these, even if they have comorbidities, may well benefit from further referral and escalation. And we are hearing about people who are doing very well, who are in the older age group, for example. If we feel that they are not going to benefit, then we move down this treatment protocol. Of course, at every stage, psychosocial and spiritual support. And remember, there may be people who start invasive treatment and that has to be withdrawn. That's a painful decision. And of course, it's better not to start than to have to stop. And we would like in general to make these decisions based on the best clinical outcomes and the preferences of our patient and family. If they're not likely to benefit, reach a consensus as a decision-making group. Try not do this as an individual. That consensus may need to be checked by a triage supervisor, but document that decision and also communicate it to the family. If you have an ethical guideline in your setting, please use it. And if you have an ethical committee, please be aware of it, because if there is a controversial decision, you may need to go to it. But can we, as far as possible, work with the families to communicate honestly and openly, and to be on the same side. We're all there as part of that caring group for that patient. We're not in competition. And try and, if you can, use your communication skills to get onto the same side. If somebody is not for invasive management and they are deteriorating rapidly, and we know that for patients with severe COVID-19, there is a particular symptom complex of severe breathlessness and agitation. And in those patients, we may have to move very fast to good symptom control. So have your symptom control handy, particularly look at refractory symptoms for breathlessness and agitation, and remember to support the family. I want to give you just one example here. A colleague of mine, a neighbor of mine, her mother died recently. And what she is remembering from that is actually not the symptom control. I'm not saying that's not important, it is. But she's remembering the opportunity by WhatsApp to say goodbye. And she's remembering the email from the treating nurse to say what it was like to care for her mother at the end of life. So this is a time when you may need to work with other team members, particularly those offering psychosocial support, to make sure that those communications, even at this end of life and bereavement stage, are still done well. It may make a big difference to that family. I think we've worked through that. Okay, so in your algorithm, there are also some guidelines, and we've covered these to some extent, but let us just highlight them. Communication and documentation at all stages. Having this system of triage, which includes an acceptance that for some patients, there is futility in escalating treatment to a critical care setting. We may be doing more harm than good, and we need to then have these conversations early and promptly and effectively. Some settings are having wards where you can go for management without invasive interventions. Some are discharging home. Your own setting will be different. We can discuss that. And I've already mentioned the refractory symptom management guidelines in our ebook. It's algorithms 1 and 3, and guidelines on end-of-life care, which again you'll find in our ebook. I mentioned the WHO performance scale, a way of just trying to assess how able this person was in terms of their functional daily activities. I think you'll be familiar with this. It really just takes you through. And those who are not going to benefit from escalation are really those in number 4 and some in number 3. So this is not a scale to try and rule out people for intervention. It's a scale to help us contribute to making these decisions, along with scales that are used within intensive care settings, such as organ failure scores. I mentioned another scale here because you may come across this. We've chosen to use the WHO scale in our triage document, our algorithm. But you do see some using this clinical frailty score, particularly in the UK. It was developed in Canada. And again, on this scale, it's 5 and above. So people who are really very limited in terms of their frailty and their ability to function, or who've got an illness that is expected to be reaching end of life phase within the next few months, that come into this. Okay. Just to try and pull this together in the last few minutes. I like these principles. They're put into actually a 2009 document, which was designed for managing the influenza pandemic of that year. And they've been revised for this pandemic, COVID-19. And it talks about making sure that your decision-making and measures are accountable. We've talked about that within our framework of ethics. That they're inclusive, we're including the patient and the family and other key stakeholders. That they're transparent, both in the way you've communicated them and the way you've documented them. That they're reasonable. You know, we're not there as somehow saviors in the situation. We're there as clinicians to do reasonable, good, excellent medical practice. And we need to be flexible. The situation is changing. Right now, in many of our low and middle income settings, the pandemic has not reached the stage where resources are overwhelmed. But we have to be flexible and have some strategies in place to how we're going to manage each step of the way. So in summary, have your ethical frameworks in place. Remember good communication. Document, communicate. Have some supervision in place. Some settings have a triage supervisor that when the team make a decision, they pass that on, and there's a check right on the ground locally. Some places call that a 3 wise men review. Remember your institutional settings and your legal frameworks. And really, really importantly, remember holistic support. A family that is struggling to think through these goals of care may need holistic support more than they need anything else in order to make those decisions well. And do remember, people are feeling discriminated against and abandoned, and they therefore may become defensive. Some elderly people are feeling as though they are being rejected and told they're not worth anything. People who have disabilities are thinking they don't count for anything in society if they're not triaged into an intervention line. So be very careful to value the person in front of you. Everyone has a right to this, to treatment, but it's not the same treatment that we're going to advise for people, as it's not in day-to-day practice. I want to come back just as we finish into this idea of humanity. I asked you about your values. I wonder if anyone wrote down values of humanity, if anyone thought about that. But I've been very moved reading accounts of people who are involved in these triage discussions currently in high pressure situations. This article was written by a New York emergency physician, and she first of all started quoting her colleagues in Italy. And then, of course, the pandemic moved, and suddenly New York was absolutely in the middle of this. And we see this colleague in Italy talking about how hard it is to stay human, almost needing to block off from what's going on in order to cope. And I think we can identify with that, almost like a sort of battle fatigue situation where we can't even think about this. You see the New York physician saying, my job in ER is to push the mortality to the edge. This was what I promised to do for every patient, everything possible. But it's actually moving to, in fact, I think a more nuanced position. But in moving to that position, can you see how she's feeling? Helpless. I have never felt less useful. She talks in the article about how palliative care colleagues have come and helped her with these decisions. But she has realized herself that being human is what matters most in the end for patients and families, and I think for herself. And the same conclusion was reached by this Italian doctor. Staying human is painful, but it's what I need to keep working. We're going to look at these issues more in a session on burnout. But I have a student from Gaza who used this term, humanity until infinity. Gaza is a situation where life can be very hard. And I think this is important. Let's keep hold of our humanity. Let's stand together. Let's support one another and make these decisions, do our jobs in a difficult and challenging environment, but do them well and to do them reasonably and to do them flexibly. And I wish you all every success as you make these steps. And I also wish you to be good to yourself and to those around about you as we face these things together. Thank you very much for listening. And I now look forward to discussion on the issues that we've been raising in this webinar. Thank you.
Thank you, Myra. Any comments or questions? Anybody?
People are digesting. Maybe people can talk about how some of these things work out in their own setting, or whether there's particular issues in this whole area that you would like to discuss or to share?
Dr. Vikas.
Hello, am I audible?
Yes, you are audible.
Yeah, on the daily basis, in generally our palliative care setting, we see that most of the we deal with the patients who are at the terminal stage of cancer. And in this COVID crisis situations, the patients somewhat in 10 patients, 1 or 2 may have that situation of end of life care. And sometimes I just feel that we are being more sympathetic than empathetic. How to work as an empathetic physician in this situation? Thank you.
So that's a very interesting point. Thank you. Can you tell me, Bikash, before you go offline, what do you think is the difference for you between sympathy and empathy? Do you mind me asking you that question?
Yeah, just ma'am, I just feel that sympathy is it's a human behavior to every human or any living beings. And empathy means to see in an ideological way that we can support. But between this empathy and sympathy, sometimes the balance is quite difficult to maintain in that scenario.
Okay. Thank you. And I think, you know, sometimes these are just our kind of words, aren't they? But what you're talking about is just the general way we should treat everybody versus how we actually maybe put ourselves in someone else's shoes. Sometimes that's said for empathy. I would say that we can never fully put ourselves in other people's shoes. What we can do, though, is create a space in our communication, even if it's a short one, where that person feels as though we're listening to them. So I think empathy is as much showing someone that what is important to them, you are listening to and is important to you. And that's where we can use these phrases, which are things like permission phrases. This must be a very difficult time for you. I can see that there's a lot of fear for you as you face these next few weeks, or a lot of worry for you. So those are ways we can just give permission. And then we can even validate. We can say, I think anyone in your position could understand the feelings that you're going through. I don't say I understand just because I don't think I can fully understand, but I can say I can validate it. You know, I'm not at all surprised that you're feeling the way you do. Is there ways in which you would like us to help you? So you're just creating those spaces to say you're important, you are valuable, your life is significant, and we're going to do all we can to give quality and meaning in this phase of life. The other thing I'd like to also say, Bikash, is that if you're working in palliative care, you have an opportunity right now to have as many of these conversations in advance as possible, so that we're not having to have them by an ER doctor or an acute physician in a very difficult medical scenario. Does anyone else want to comment on the very important issue that Bikash mentioned?
Can I add in a comment? This is Shobha here.
Sure.
Hello. So last year, I think we read an article. Some of us in this group also probably have read that. An article on sympathy, empathy, and compassion, and what do patients want. So what they related sympathy and empathy was, sympathy is a feeling that we have, but we don't actually act on it. Whereas empathy, you try and include the patient's feeling and reflect on what you can do, but compassion is actually doing it. So when they did a study on what would people prefer, everybody felt that, you know, compassion is the best. So the action on what you feel, the empathy that you feel, is compassion. And sympathy is like you're kind of overwhelmed with sorrow and you can't do anything. You're feeling very sorry for themselves, but you're not acting on it. So the acting part is what makes the difference. And that is traveling towards empathy, feeling for them, and then doing something for them. So that's compassion. So that's what we read. It was a very interesting article that we read last year.
Thank you, Shobha. And the word compassion comes from an old Latin word, which means to with passion, you know, with heart. I see a very interesting question. I think Dr. Sandeep, you may want to say more about it, but you're absolutely right. We need to be working with our ER physicians and ICU physicians. Here in Makerere in Uganda, we have actually trained all of our ICU physicians in palliative care, and we've been jointly working. We've also trained our acute care physicians in the ER in palliative care. Of course, we also have to understand their context, so it is a genuine team working. But please do work with your local ER or ICU physicians. And if any of you on this call are ER ICU physicians, please make a comment on this issue.
Yeah, thanks, Moira. Because about 3 weeks ago, I started Let's have discussion. So as a family physician can have word in the community beforehand. There are elderly population and multiple morbidities. As a family physician, one person in a better way, not at the end of the time when you really have to put all your resources. So make the time frame utilized during the initial days. But couples, the mindset was not there, is not there. And especially during the, as an internist or a acute care physician, okay, it's a hyperacute, we'll talk about later. So I believe, as you rightly said, a teamwork and inclusiveness is more important. Thanks.
And I think you brought out the role of the primary care and family physician, one of the most crucial roles here. I know in different parts of the world it's not so well developed, but this is a really important role. I would also like us to feel some empathy for our acute care clinicians. You know, you read those quotes from that young doctor who was used to saving lives only and is now faced with the reality of mortality in a way that maybe hadn't been before. So this is a fantastic opportunity to really work together and to support each other and to lend the skills that we have to one another.
Biju?
Hi, this is Dr. Biju Raghavan. Just adding on to this topic of sympathy and empathy, just a couple of thoughts. Sympathy is something that we, for example, feeling sorry for somebody who is in an unfortunate situation. And that comes easy to us, feeling sorry for somebody. Now, problem is when we feel sorry for somebody, that does not do anything worthwhile for the person who is in that unfortunate position. Empathy, on the other hand, is we trying to figure out how the person must be feeling. That, as Moira said, trying to be in the other person's shoes. And I agree, we can't ever be totally in the other person's shoes because we are not that person. So one way we can work around that is, for example, if I have an elderly gentleman who is in a very bad way, and I have to take some kind of a decision for that person. Uh, I'm I'm fairly aged, but not elderly to say, so I can't be in that shoe. But I can think of my father who is no more, and think if this person were my father who is no more, and if my father was in that position, what would I have done, or what would have been my decision? So that is one way of taking decision empathetically. And as far as showing empathy is concerned, Moira did came up with very good permission statements. And another thing that I usually practice is when somebody is in that unfortunate situation, patient or the family member, one statement that I usually make is that I can imagine what you must be going through. Many times I have seen people saying, "Oh, I understand what you must be going through." Please remember that we can never ever understand what the other person goes through. So the better statement would be, "I can't imagine what you must be going through." That's a more honest statement, and it shows empathy. So that is just a few things that I wanted to say. Thank you.
Dr. Bijou, you were once my student, so if you're elderly, I don't know what that makes me. And secondly, those who haven't listened, a long time ago, those who haven't listened to his Dr. Bijou's
You're
excellent talk.
ever young, Moira. You're ever young. You're evergreen.
If you haven't listened to Dr. Bijou's excellent session on communication, please find it. And please practice some of those statements. Don't suddenly be faced in a situation that's difficult and not having thought of them, and practice them in your local language. Thank you for giving us another way we can do it. And remember, it's okay to be silent. If somebody said something that's quite difficult, you can leave a moment and then you can say, I can see this is very distressing. That's a moment just to hold that silence. The reason why empathy is important, whatever way we want to call it, is because it gives value. And if a person and a family, if a patient and a family feel that you are valuing them, then even if you're suggesting a management option that wasn't their initial preferred option, they may well trust you enough to be able to then go forward on that discussion. If they feel that you don't value them and you're not interested and they're simply a statistic or a number, and even worse, a discriminated group, they're going to fight you every way.
Okay, thank you, Moira. Any more comments or questions?
Somebody wants me to share the second last slide. Let me just put it up. You find this in the New York Times Magazine. It was an article just the other day.
That's an excellent slide, Moira. Thank you for that.
Oh, and someone wants me to share the slide below. I think you'll be able to get all of these in due course, but let me just see the slide below. And we'll try and include looking at empathy. We're going to have an excellent talk on psychosocial issues soon. So I think that issue of empathy may come up there, Bikash. I think is it Dr. Seema that's doing that talk this week? So please look out for that. I also want to let everyone know that we're going to be filming quite soon standard webinars on all of these topics, and all your comments and feedback are very helpful for us in finalizing those standard webinars. Thank you.
So, Mero, you were talking about WHO performance status. So, what status is that? Is it the pre-COVID status or post-COVID status?
Oh, thank you, Sunil. These are all pre-COVID, because the COVID itself, of course, may make somebody very unwell. So this is not, we are assessing the COVID, we kind of know how to do that. Yeah, and in our algorithms, you'll see in other ones, it's talking about the hypoxia, the respiratory rate, and so on. We also know that people with COVID-19 are having quite severe hypoxemia even before they look like they're in respiratory distress. It's a very interesting medical phenomenon that so I think increasingly people are, putting my finger up for a pulse oximeter, increasingly people are keeping an eye on the oxygen more than just looking at the general condition of the patient. And this maybe explains why people who looked very well suddenly are deteriorating. Having said that, what we want to do when we're having these goals of care discussions is not just assess the current situation, which is due to the COVID-19 infection, but what was their pre-COVID functional status and comorbid status. As I say, ICU physicians usually score that using something like this organ failure score, and that is to help assess outcome of triage. And if you look at that paper I showed you, you can see details of that. Now that's for an ICU physician. So when they get to ICU, they have these kind of scorings. We are trying to help make, in this algorithm, make that decision before ICU. How do we decide who to send for critical care assessments? So the critical care assessment will use these organ failure tools. We wanted something a little bit more straightforward for frontline healthcare workers, including in the primary care setting. So that's why we chose the WHO functional status. And if this is working, it's not. I would take you back. Yeah, there we see. So it is really saying, is this person, due to their comorbidities and their frailty, able to look after themselves and be reasonably functional within their own environments? Or are they spending more than 50% of the day bedridden or even completely unable to look after themselves? It's those categories 3 and 4 that will make us then look at their comorbidities, look and see if there's any illness which has got life-limiting consequences that is imminent, and help us make those decisions about goals of care.
Thank you, Moira. Anybody else?
I think we have, do we have some people from Sri Lanka on the call?
Yeah, we have.
Do you want to make any comment about how things are in your own setting in terms of these issues?
Colleagues from Sri Lanka? I don't think there is any questions or comments, Moira.
Lovely.
Do you have anything more to say on this?
No, I think this is a tricky issue. I thank you for all the comments, and I really would encourage you to work with your teams. You all have really important roles to play in this at different times and different places. And maybe this outbreak will mean we form linkages that we didn't have before, and maybe even will improve care going forward. I apologize, those are birds flying above me here, and encourage you to remember your humanity as well.
Thank you. So thank you, Dr. Moira, for your wonderful session. And thank you all for being interactive. And we'll see you tomorrow with psychosocial interventions in COVID-19 taken by Dr. Seema Rao.